Okay. Hello, everybody. This is Dr. Jannat or Akter Riva. I welcome you all to the first session on cardiology. So there will be consecutive three to four classes, depending on how much we are able to cover. Cardiology topic is quite vast, and it can be a little bit difficult in comparison to the other systems. Particularly for the fresh grads, because we are not acquainted with cardiology or cardiac management on a day-to-day basis. It's considered a specialty branch of medicine. However, most of the cardiac emergencies, this is something that we have to deal with, even though we are not having any specialty degrees in cardiology. So that's why having a very, summarized idea, not only for exam purpose, but at the same time in terms of managing patients with cardiac emergencies and how to monitor a cardiac patient. So these are very important and practical knowledge, which is why I would like to request everybody to pay or focus extra attention to my classes. Apart from that, from exam perspective, it's considered one of the major system. So you can expect at least 15 questions coming from cardiology. And these questions will be scattered again throughout the two papers, that is paper 1 and paper 2 for part 1 examination. So in total, you can expect around 15 questions. Sometimes the number of questions coming from cardiology, if you incorporate basic clinical science or into cardiology as well, because you'll see like in the beginning of the cardiology, there's some information that are also discussed in physiology section as well. So if you consider that, sometimes the number of questions can be, more than 15 questions. It could be somewhere between 18 to 20 questions even. So that's why I think it's very important as a system from a practical perspective as well as exam perspective. Most common topic for cardiology, it's usually basically cardiac arrhythmia. This is most important for exam purpose. Apart from that, management of coronary syndrome, particularly the acute coronary syndrome, and other cardiac emergencies such as cardiogenic shock and acute left ventricular failure, pulseless ventricular tachycardia, and the other types of broad complex tachyarrhythmia, even bradycardia. These are all very important topics. So in generally, I will focus particularly on three topics. That is, in first class, I will actually divide my class into mainly two emergencies. That is cardiogenic shock and ischemic heart disease or the acute coronary syndrome. I will also side by side focus on heart failure. And if I have some time, then I will go through the cardiac arrhythmia. In the second class, I will discuss in details about the cardiac arrhythmia, particularly the theoretical bits. And also, I will discuss about some cardiomyopathies and disease of cardiac muscles and endocarditis, myocarditis, these stuff. In the third class, I will actually go through some of the basics as well as the remaining portions such as congenital heart disease and stuff like that. And also interpretation, just basic interpretation of cardiac catheterization. Because for part 1 examination, you do not have to have like detailed knowledge regarding the cardiac catheterization interpretation. Just the basics will help you to, give answer. That will do. So I think a lot of us have like some form of, hesitancy in terms of whenever there is ECG interpretation. While ECG is very important for part 2 written examination, but there are some common or classic ECGs that usually come in any part of MRCP exam. And the commonest one being myocardial infarction or MI. So it can be either two type, that is ST elevated MI or non-ST elevated MI. For part 1 examination, actually ECG interpretation does not usually come. In my examination, I had one ECG coming from the WP syndrome. And the other one was basically a management related question where the ECG was showing anterior ST elevated MI. So just generally, you have to like go through only the very stereotypical finding of the ECG, and I think that will be enough. Not a lot of complicated, like you don't have to go through the Garbosa criteria or anything like that to diagnose MI from left bundle branch block. So those complicated scenarios usually do not come. Okay, now without any further ado, I will start with our today's case, basically today's topic. I will start with basically ischemic heart disease first. So let me just write down your informations. most important. I will just write down the important information again, just to give an idea about how the entire class for today's session will be. Cardiac arrhythmia, it will come actually, it's very important, but I will discuss it in the later part of my discussion, because there is some residual knowledge that you will be requiring to jump to this particular portion. Ischemic heart disease. So this is again very, very important 3-star topic, but this is 5-star actually. Okay, ischemic heart disease. So I will start with this one first, and I will also discuss about heart failure. And number 4, this is the topic that I will be mostly focusing on today, and that is cardiac emergencies, dealing with cardiac emergencies. Okay. So these are a bit summarized version of how I will give how I will deliver the lecture today. But once you're done with my lecture, if you start reading from this particular topic in your lecture sheet that is provided to you by Dr. Academy, you will see like there is lots of similarities. So you don't have to worry about that if I'm not going through topic by topic, like page by page. If I'm not going like that, don't be bothered. All of these are given within the lecture sheet. So nothing new information will be coming from me, just in a bit more summarized way. All right. So in terms of ischemic heart disease, first, actually, we will discuss about what is coronary syndrome, acute coronary syndrome. So among the cardiac emergencies, acute coronary syndrome being the most common one. So it has like some subcategories, that is unstable angina and myocardial infarction or myocardial ischemia, which can be a further 2 types, that is ST elevated MI and non-ST elevated MI. So these are particularly within the acute coronary syndrome. So of course, if it has the name acute in front of it, so there must be something that is known as chronic coronary syndrome. So chronic coronary syndrome is basically nothing but chronic stable angina. So this used to be known as stable angina previously. Nowadays, it's all considered a part of spectrum of the chronic coronary syndrome, as well as chronic heart failure. These are also considered to be part of the chronic coronary syndrome. It's actually quite vast spectrum, okay? But the most common one being chronic stable angina. Now, imagine this is the heart. So what are the diseases of the heart? So that's the main question, right? Okay. So this is right atrium, right ventricle. This is left atrium, left ventricle. And from here rises the arch of aorta, and right ventricle arises the pulmonary trunk. So we know that the superior and the inferior vena cava drains into here. There is SA node, AV node, then basically bundle of his, and this is left and right bundle and Purkinje fibers. There is also like some coronary sinus draining into the right atrium as well. And from this, in the arch of aorta, in the acidic aorta, there are 3 dilatations. So these are particularly the dilatation. The cross section will be looking like this. So one is the right sinus and the left sinus. This is a non-dominant sinus. So from the sinuses will each of the coronary artery arise. So from the right aortic sinus, the right coronary artery arises, and from the left aortic sinus, the left coronary artery arises. So supplying different parts of the heart. So basically, if you try to look at the pathologies of the heart, then you will see that there isn't much to discuss here. So it's either if the problem is within the vasculature, that goes within the ischemic heart disease. If the problem is in the pulmonary trunk, that goes in the pulmonary hypertension. If the problem is within, for example, aorta, then you have the aortopathies or aortic disease. So there are different types of aortic disease. It could be aortic dissection, it could be aortic aneurysm, blah, blah, blah. Anyway, and if the problem is within the, basically, the valves, that is the mitral, tricuspid, or the aortic and pulmonary valve, that is within the valvular heart disease or valvular pathology. So mainly the endocarditis. Okay. If the problem is within the muscle, this goes in the myocarditis. If the problem is, or cardiomyopathy, whatever. If the problem is within the covering of the heart, this is known as pericarditis. Okay. And within that entity, you have the pericardial effusion, cardiac tamponade, and lots of other possibilities going on. And if the problem is within this, like electrical pathway, or the conduction abnormality, that goes in the cardiac arrhythmia category. So you'll see that, and of course, if there is some congenital abnormality which can affect in any part of the heart, so that goes within the congenital heart disease, which is further divided into cyanotic and acyanotic congenital heart disease and some complex congenital heart diseases. And among the cardiac tumor, basically, it's not really that common place where the tumor can rise from. However, left atrial myxoma, which is a type of benign tumor that particularly involving which can particularly happen in the heart. So that's like a separate entity. But heart is actually not the common site for metastasis or not a common site for primary malignancy source either. So you'll see like the entire heart diseases are actually within not that vast, but a lot of systemic diseases ultimately can cause complications in the heart. And this is such a vital organ, which is why so much importance is given on the cardiology. So anyway, we're moving to the ischemic heart disease portion. So basically problem within the blood vessels of the heart. So blood vessels of the heart, it is further into, it has like separate spectrums, the ischemic heart disease, not only divided to acute and chronic coronary syndrome. So if you consider ischemic heart disease, so it has like couple of spectrum or the way it manifests. ACS being the topmost priority or important one. Then we have the chronic coronary syndrome. We have also acute left ventricular failure, as well as congestive cardiac failure or chronic heart failure, and cardiac arrhythmia. So ultimately, what happens is like why we're considering cardiac arrhythmia within ischemic heart disease as a part of spectrum, because people who are suffering from ischemic heart disease, they can also present with different types of conduction abnormalities as well. Thereby, the manifestation will be within this spectrum. And of course, ischemic heart disease sometimes being so massive, the first presentation of ischemic heart disease can be sudden cardiac death or SCD. So these are all within the ischemic heart disease spectrum. All right. Now, in terms of the acute coronary syndrome, like we have already discussed, like unstable angina. So unstable angina, imagine the cardiac chest pain. How does a cardiac chest pain feel like? So cardiac chest pain, most of the time, it's usually, we know this from our undergrad level, like this is a sudden onset central chest pain, which is usually crushing, burning, squeezing, causing so much discomfort. Patient might feel like there is a feature of impending doom or something like that. Patient might be associated with nausea, sweating, and at the same time, this type of pain usually radiates to the, like shoulder blades or the left arm or the root of the neck or the jaw. Patient might be having like profuse sweating or about to lose consciousness or the worst type of pain the patient has ever experienced. However, there are some exceptions. For example, in elderly patients or people who are diabetic individuals, their autonomic nervous systems are not actually that much potent or efficient. So in that case, they might not be having like typical cardiac chest pain. Rather, they might be complaining of vague chest pain or feeling of restlessness or agitation, but not specifying the chest pain itself. Sometimes upper abdominal pain can mimic cardiac chest pain as well. So if a patient is suffering from this type of chest pain, however, there is no ECG changes or there is basically no rise in cardiac biomarkers. So that is known as unstable angina, okay? And patient is not, this type of pain is not relieved by taking rest or GTN spray, which actually makes it a separate entity from the stable angina, because we know that stable angina patients, after taking rest for a while or after taking the GTN spray, they start to feeling a little bit better. All right. Now, in terms of the other entities, that is the myocardial infarction or myocardial ischemia. So there is like two distinct difference between the term ischemia versus infarction. So myocardial ischemia basically means like cutoff or loss of blood supply, okay? But the area of the myocardium that the blood channel was supplying, it has not necrosed yet. But when after like doing a pathology, histopathology, if you see that the full myocardium is actually the blood supply is cut off and now the myocardium is dead, or there is necrosis process has already taken, that is known as infarction. So this is basically the difference between myocardial ischemia and infarction. However, in terms of clinical assessment or clinical management, there is no basic difference. So this is further of two types, that is ST elevated MI and non-ST elevated MI, like I've already mentioned. So ST elevated means that if you consider this is the myocardium and this is the blood channel, okay? So this area is entirely necrosed, or there is no blood supply here in this particular region. So in that case, this will be manifested as ST elevated MI because the full myocardium thickness is involved here. But in case of the non-ST elevated MI, what will happen is that in the myocardium, there is partial, like necrosis or partial changes taking place, not the full myocardial thickness. So this is known as non-ST elevated MI. Now, in our undergrad level, what the teachers used to love talking or asking us is that which MI do you think is actually worse? But over the time, I tried to like make sense of it, like what exactly. I know that a lot of undergrad levels, they wanted to know about the non-ST elevated MI because there is no significant change in the ECG. There is no significant rise in the cardiac biomarkers, which mimics, it's only the chest pain that is the most prominent symptom, very much like the unstable angina. So that's why they would be like, it is usually not diagnosed at an earlier stage, and patients are usually, it goes underdiagnosed, or that's why it can have a poor prognosis. However, I have also thought about this, and I think that like if we compare the histopathology or at the like the bottom of the disease, in that case, of course, full myocardial death is actually having worse prognosis, because the ST elevated MI, if you don't go for primary PCS strategy as soon as possible, of course, this can cause further damage to the heart and ultimately cause heart failure or cardiogenic shock entirely. So in terms, both have their own, like flaws or, poor prognostic features. Anyway, I'm happy that we are not, like sitting in front of the Viva table and asking, answering this weird questions. All right. So this is the basic difference between the ST elevated and the non-ST elevated MI. So in the ECG, if you look at the ECG, this is normal ECG, PQ. RST. So in terms of the ST elevation, what will happen is that there might be like convexity upwards, the ST, and T wave might be inversed. So T wave inversion and ST elevation, these are the main significant changes. And do remember that this type of ECG changes should be in consecutive leads. Like if you're getting any discrepancy, for example, you're supposed to get ST elevation for if it's an anterolateral ST elevated MI. So you're supposed to get the ST elevation in lead 1, 3, plus minus AVL, or any of the chest leads. You should be seeing those changes. However, if you see like ST elevation is also present in the inferior leads as well, that is virtually impossible to, like affect all the coronary arteries at the same time. So in that case, you should definitely go for a repeat ECG because there might be artifact present or something, some type of technical abnormality might have happened. And in case of the non-ST elevated MI, ST depression is usually in the chest lead, usually more than 2 millimeter, and in the limb leads more than 1 millimeter. ST depression, that is significant. Similarly, in case of the ST elevated MI, ST elevation should be more than 2 millimeter in the chest lead, and ST elevation should be more than 1 millimeter in the limb lead. All right. So apart from the clinical presentation, like the one I have just mentioned, like the chest pain and the complaints of chest pain, how would you like to evaluate or assess a patient with cardiac chest pain? So always, this is an emergency. So always start with ABC resuscitation protocol or ABC assessment. So you have to check for the patient's airway and of course, breathing. If the patient is having GCS score, for example, in a MI patient, if you see that the patient is becoming drowsy and not able to talk or anything like that, not responding to you properly, GCS is less than or equal to 8. In that case, there is indication of going for mechanical intubation as soon as possible. C is for circulation. You already know that. So here, monitoring of the pulse, blood pressure, and jugular venous pressure and CV pressure or central venous pressure. These are all very much important. And D is for disability. And so you can assess that by doing the GCS scoring. E is for exposure. However, well, exposure to, put the chest leads, and if you are going for thrombolysis as soon as possible, in that case, exposure is very, very important. And then what you do is, after doing the ABC resuscitation protocol, you have to check for the patient's oxygen saturation. So oxygen saturation, why this is important? Because if the oxygen saturation is less than 90%, in that case, there is indication of going for high flow oxygen in myocardial infarction. Previously, oxygen was given routinely to any patients who are suffering from MI. But nowadays, there are like protocols and guidelines that says that if a patient is maintaining oxygen saturation quite well, there is no need to give any supplemental oxygen because it can cause further injury by producing free radical. So that's why if the oxygen saturation is low, in that case, you can go for oxygen supplement to the patient. All right. Bed rest is very, very important. You have to hospitalize the patient immediately, obtain an ECG, and send out the important relevant investigation as soon as possible, open an IV access. So you should do all these things side by side, take a quick history at the same time, assess the patient, examine the vitals, auscultate the precordium, check for the legs and everything, and check for the neck to see the JVP. So you should do all these things side by side. And usually in terms of investigation, we usually start with a complete blood count with ESR-CRP because in inflammation or myocardial infarction, ESR-CRP tends to be high. Sometimes the total WBC count can also be high, but it's not like bacterial or infection-like picture. So that particularly occurs because of infarction. This is an acute stage, so that's why the WBC count is high, but neutrophil lymphocyte counts tends to be normal. And then you have to check for the RBS because most of these patients, they have comorbidities such as diabetes, hypertension. So RBS, lipid profile, SGPT level, cardiac biomarkers such as TOPI or CKMB, whichever, depending on your cardiologist's decision. We usually give for both TOPI and CKMB side by side. And so usually these are the common investigations that are given. Sometimes if the time permits, you can go for chest X-ray, PAView, and urinary as well. But these are, like some additional tests, not as part of the important investigations. And next up is in terms of management, okay? So this is the most important part. So in terms of the management, if the patient is having ST elevated MI, so in that case, we will start with, after doing all these things, we will give a bolus dose of aspirin and clopidogrel. Aspirin 300 milligram bolus dose, and a second antiplatelet agent, that is clopidogrel. Or, some trust usually like giving ticagrelol as well. So ticagrelol can be given like 180 milligram stat dose. So prasugrel, if that's the trust protocol or the hospital protocol. So any of the second antiplatelet agents, this is considered that glycoprotein 2B3A receptor blockers are more superior to clopidogrel. So this should be given in bolus dose and IV morphine or pethidine. In our hospital setting, we usually give pethidine, but actually this also depends on the hospital protocol. So if your hospital is supplying for morphine or diamorphine, in that case, you should go for that. IV morphine plus antiemetic such as ondansetron, palisetron, these can be given antiemetics, okay? Now, in case of an ST elevated MI, before going for other medical management, you should opt for primary PCI strategy. So primary PCI strategy is considered to be door to needle time. So whatever I'm saying, actually, these are all quoted from the American Heart Association guideline according to the latest guideline. So primary PCI strategy is usually the time window period is 12 hours, ideally. However, door to needle time is considered to be 120 minutes, okay? So that means you get the optimum recovery or outcome from a patient if from the onset of the pain to putting the patient under the, like primary PCI strategy, if the you get the optimum outcome from the patient if this is within 2 hours or 120 minutes. So that's why this is considered to be a golden time. This is known as the door to needle time. However, you can stretch this up to 12 hours, particularly if you have to refer the patient to the tertiary hospital, or for example, you're working in a district level hospital, there is no PCI strategy available. In that case, you have to give the medical management and send the patient as soon as possible to be considered for a PCI within 12 hours. Okay. So this is actually a primary PCI strategy. And if the patient is not having any PCI, facilities available, so in that case, what you can do is you can consider fibrinolysis or thrombolysis. If there is no contraindication, of course, and with an expert hand, of course. And if the patient is, so the contraindications for fibrinolysis and how it is done, we know that in our hospital setting, in most of the government hospital in Bangladesh, streptokinase is actually provided by the government facilities. However, streptokinase has lots of side effects. So in comparison to some newer generation, for example, tissue plasminogen activators are considered to be superior. So for that, alteplase, tenecteplase, retiplase. So these are actually more superior than the streptokinase. That is usually given subcutaneously, mixed with the normal saline in bolus doses. With alteplase, usually concomitant low molecular weight heparin is also given by infusion. With tenecteplase, only a single bolus is enough. All right. So what are the contraindications? In which condition you should not consider giving fibrinolysis or thrombolysis? Number one, if this is not ST elevated MI. So there is virtually no importance of going for fibrinolysis or thrombolysis strategy in a non-ST elevated MI. So if there is no ST elevation, don't go for this. Number two is if the patient is having any contraindications such as, for example, any bleeding disorder. So in that case, you should not go for that. Number three is if there is any recent ischemic stroke in less than 6 months or transient ischemic attack. And four, if the patient is having any cerebral malignancy or, like AVM. If the patient is having any hemorrhagic stroke, anytime in the past even, you cannot go for that. And if the patient has any like bleeding peptic ulcer disease, had any surgery or any history of any injury to the head or neck region or any major surgery that was conducted within 1 month, in that case, you should definitely not go for, thrombolysis. There are some other minor contraindications as well. For example, pregnancy, lactation, and refractory hypertension. If the blood pressure is more than, for example, 180 over 110, or significant liver failure, renal failure. So in those causes, actually, these are actually relative contraindications. So risk-benefit ratio is considered before going for thrombolysis. But absolute contraindications are hemorrhagic stroke, recent ischemic stroke, cerebral malignancy or AVM, patient having bleeding disorder, active bleeding peptic ulcer disease. So these are basically the major contraindications. All right. However, if after going for fibrinolysis, you still have to refer the patient for the PCI strategy, particularly if it is unsuccessful. So that is known as rescue PCI, not the primary PCI strategy anymore. All right. Now, in terms of how do we manage a case of non-ST elevated MI? So here, more emphasis is actually put on the medical management rather than the invasive or intervention procedures. So medical management, similarly, like as the ST elevated MI, we start with antiplatelet, that is aspirin, clopidogrel, and morphine, antiemetic, and then GTN spray. Of course, GTN spray, it can be given in a spray form or, like 2 tablets, 0.3 milligram sublingual tablet form as well. If the patient is having like good blood pressure as well, in that case, some trust can also go for IV nitrate infusion as well. However, that should be done cautiously because it can cause venodilatation and lower the blood pressure. And it can actually ultimately cause cardiogenic shock or precipitate cardiogenic shock. So that's why IV GTN should be considered very cautiously. All right. Then you should consider beta blocker as well. However, there are some contraindications. For example, if a patient is having any severe COPD or asthma or bronchospasm, And if the patient is having acute heart failure at the same time like side by side with the ischemic heart disease, so in that case, beta blocker is not usually ideal. Rather than you can go for rate limiting calcium channel blockers such as verapamil or diltiazem in that case. So, and of course, you can start with the statins and ACE inhibitor, but those are actually considered, like prognostic roles. So during acute management, they do not provide much importance here. So then you have to consider whether the patient is having high risk versus low risk. And in order to do so, there is a scoring criteria, which is known as the GRACE scoring. GRACE scoring is the global registry for acute coronary events. So this GRACE score is actually quite elaborative. There are lots of parameters going on. Most of the trust or the hospital, they have the GRACE score written on the cardiac emergency side. And you can calculate the GRACE score over there, or you can calculate the GRACE score also using your Google as well. So in general, the way we like consider high versus low risk is if there is any dynamic ST or T wave changes, ongoing ischemic chest pain, if the patient develops any malignant arrhythmia or goes on to developing cardiac syncope, and if the patient has secondary risk factors such as diabetes, CKD, left ventricular ejection fraction is less than 40%, and recent PCI, past history of CABG, or angina after recent MI. So these are all considered, like risk factors, high risk factor. So if there is any high risk factor to moderately high risk factor, in that case, what we do is we give the patient anticoagulants, either depending on the trust, fondaparinux or bivalirudin. If the trust does not have this direct factor 10 inhibitor, in that case, we can also go for low molecular weight heparin as well, or unfractionated heparin. And we have to consider the sending the patient for angiography. So plus cardiologist consultation, and concurrently, if there is an arrhythmia, that should be treated side by side. However, if this is a low-risk patient, so there is no dynamic ST or T wave changes, the patient is not having any significant symptom right now, and there is no malignant arrhythmia, there is no cardiac syncope going on, then the patient's secondary risk factors are, like, okay, controllable, understandable, nothing significant or nothing that we need to be thinking about. In that case, we can just, keep the patient with ongoing medical management. And after discharge, we will discharge with the antiplatelet maintenance dose and the other medication as well. And we have to, check the patient in cardiology outpatient department for further tests such as a stress test or ETT, something like that. It could be myocardial perfusion scan, etc. So that is something that we do later on, not right away. But if there is high risk factor, in that case, we have to send the patient for urgent angiography as soon as possible if the score is quite high, GRACE scoring. So I think so far acute coronary syndrome management is quite understandable from you. So now I will go to the lecture. All right. So here you can see that among the cardiac enzymes and the cardiac biomarkers, myoglobin is the first one to rise. You can see here, it begins to rise within 1 to 2 hours. The peak value reaches within 6 to 8 hours and returns back to normal within 2 days. CKMB, on the other hand, it also takes 2 to 3 days to come back to the normal. I want to focus on here, that is troponin T or troponin I. They usually persist in the blood for 7 to 10 days, which is why CKMB is useful to look for reinfarction, as it returns to normal after 2 to 3 days rather than troponin T, because troponin T remains elevated for up to 10 days. All right. So here you can see the arterial supply of the heart. The basic is basically from left aortic sinus comes the left coronary artery, right aortic sinus comes the right coronary artery, and the left coronary artery is further divided into the left ascending, left anterior descending artery and the circumflex artery, or the LCX. And RCA gives branch to that, actually continues running as the posterior descending artery. And RCA, or the right coronary artery, supplies the SA node in 60% individual and AV node in 90% individual. So that's why we have the right coronary artery dominant circulation in most of the patients. And in some patients, in very small percentage of the patient, the SA node can be supplied by the left circumflex artery. So those patients or those individuals that is a normal variant as well. So those individuals are known as the left dominant circulation. Venous drainage, all the veins of the heart ultimately drain into the coronary sinus, which drains into the right atrium. So now I want you to focus on this question. All right. Here you can see that a 64-year-old man having dual chamber pacemaker inserted, the ventricular lead is to be inserted via the coronary sinus. And where does the coronary sinus drain into? The answer is right atrium. So sometimes what I love about MRCP is that they never ask you any question which requires, which sounds like a very novice type of, like question. They're not asking you directly, like, where do you think the right, like coronary sinus drains into? Because they will give you further clues. They will start with the clinical scenario and then they will maybe ask you some basic things. So this is how, like mature question, post-graduation level question should be like. So these are basically discussing about all the anti-anginal medication. I think I have covered most of these things so far. Nitrate tolerance, well, you have to know about the common side effects of this medication as well, because GTN, we know that it causes hypotension and postural hypotension or postural drop. But at the same time, in patients who are taking nitrate chronically, they become tolerant to it. And most of these nitrate taking patients, as there is subsequent vasodilatation, it can also cause some migraine-like headache as well. So this type of tolerance is not seen in patients who take modified release isosorbide mononitrate, which is why you will see like most of the patients in our country are prescribed with GTN SR, that is sustained release. Ivabradine, you have to know like a couple of information from ivabradine as well, because this also helps in reducing the rate thereby, and ivabradine also has similar, like prognostic value like the beta blocker. So but then again, before prescribing ivabradine, you have to make sure that the patient has no atrial fibrillation, or patient should be in regular sinus rhythm. If the patient is not in regular sinus rhythm, in that case, you cannot prescribe ivabradine, because ivabradine specifically works on the SA node in the funny channel. Okay, so that's why it has to be in the sinus rhythm. So this is a new class of the anti-anginal drug. It acts on the funny iron current, which is highly expressed in the sinoatrial node, reducing the cardiac pacemaker activity. So it keeps the heart basically calm and quiet. And heart rate should be more than 77 per minute. In that case, you can prescribe ivabradine. Adverse side effects, it can cause some visual abnormalities. Luminous phenomena are common. Bradycardia, sometimes it can be. But in comparison to the beta blocker, like beta blocker and rate limiting calcium channel blocker, they can, with high or large doses, they can cause significant myocardial depression. But ivabradine is not that cardiodepressive. Rather, they are more, vessel selective. So there is no evidence currently of the superiority over existing treatments. So if you can, again, you can give ivabradine in those particular patients who are not able to tolerate beta blocker, or in patients who are having contraindication to beta blocker. In that case, you can prescribe ivabradine. But again, remember, patients should be within sinus rhythm. All right, now let's discuss about this one. Question 178. Any volunteers? Dr. Anita, can you take question number 178, please? Dr. Anita. Okay, Dr. Fairuz, can you take question number 178, please? It's quite easy. Okay. Dr. Ananda, can you take question 178, please? Dr. Ananda?
Sorry, ma'am, I don't have my earphone today. I'm missing it. Earphone.
Okay. Can you take question 178 though?
Is it okay?
Yes, I
A
can hear you.
70-year-old 70-year-old man is investigated for exertional chest pain and has a positive exercise tolerance test. He declines an angiogram and is discharged on a combination of aspirin 75 milligram OD, simvastatin 40 milligram on, atenolol 50 milligram OD, and GTN spray. Examination reveals a pulse of 72 per minute and blood pressure of 130 by 80. On review, he is still regularly using his GTN spray. What is the most appropriate next step in management? At nifedipine, MR 30 milligram mod, isosorbate mononitrate 30 milligram BD, increase ethanol to 100 milligram, and nicorandil 10 milligram BD and verapamil 80 milligram TDS.
So, okay, I will help you a little bit. So here you can see the patient is having acute coronary syndrome, right? And we have to optimize the guideline-directed medical therapy in this patient as the patient is declining angiogram. So in that case, patient is taking aspirin, and so that is antiplatelet is already, patient is already on antiplatelet. Patient is already on lipid lowering agent, and beta blocker is already given to the patient, and GTN spray whenever the patient is symptomatic. So most of the treatments are actually given to the patient. However, patient is, like examination is revealing pulse is normal, blood pressure is normal, and regularly using his GTN spray. So that means the patient's pain is still not under well control. So you probably need to consider another medication for this patient. So in that case, what sort of next step would you like to consider?
Isosorbate mononitrate.
Okay. All right. In that, because GTN is already like a similar drug, the patient is already using GTN spray. In that case, would you like to prescribe a similar class group of drug?
And maybe atenolol should be increased in dose.
Okay. All right. So what's your reasoning behind this?
Patient is already taking atenolol and blood pressure is little bit controlled. So we can use this drug for his pain control.
Okay. But patient main complaint is pain, right? So atenolol beta blocker, what it does is like it has a longer prognostic benefit. At the same time, it helps to reduce the heart rate of the patient. So do you think that reducing the heart rate of the patient will be more sufficient or beneficial to the patient, or something that can help manage the patient's pain, cardiac chest pain? Because if you, and we have to be cautious here at the same time, because atenolol, if it is increased suddenly, the patient might be having bradycardia, which is not a good thing, right? So, okay. All right. Okay, yeah, sorry. I was actually discussing about the nicorandil, but here they are mentioning that 100 milligram daily in 1 or 2 doses, starting dose. Okay, yeah. I think they want to optimize the like medical management first. And if the patient was given 100 milligram, if the patient was still symptomatic, in that case, we can go for adding the nicorandil. So, okay, you are doctor. You answered it quite well. So as the patient is receiving 50, so up to 100 can be increased. But if the patient was already on 100, in that case, we would have added like a second anti-ischemic or anti-anginal medication. So in that case, nicorandil would have been the answer. All right. So thank you, doctor, for taking this question and answering this. All right. Next question is, yeah, this one. No, I think this is a similar question. Yeah. Yeah, question number 183. This one. Can anyone take this? Dr. Anita, I think you gave the answer for the previous question, right? So you can take this question again, please.
Okay, a 70-year-old man presents with a history of chest pain on exertion. He is known to have hypertension, currently treated with amlodipine, and he is also on simvastatin for primary prevention. The chest pain is dull in nature and is relieved within a few minutes of rest. His symptoms have been relieved by use of his wife's GTN. What additional medication is indicated here? Doxazosin, verapamil, isosorbide mononitrate, atenolol, and ivabradine. Isosorbide mononitrate.
Okay. All right. So patient is already on simvastatin and currently taking calcium channel blocker, amlodipine. Patient dull in nature and symptoms have been relieved by use of the patient's GTN. Okay. So what additional medications? The patient is already on GTN. So, all right. I think in this case, you can choose atenolol because beta blocker out of all this medication has the most, like prognostic benefit here. Patient is already taking GTN, so there is no need to go a further prescription of additional GTN. So ivabradine would have been the answer if the patient had some sort of like contraindication to atenolol. So beta blocker is the answer here. Patient is already on calcium channel blocker. No need to give another calcium channel blocker. Alpha blocker is not the traditional medication unless patient has CKD. Patient already have symptomatic relief from the GTN. So no need to add further GTN therapy here. Atenolol has a prognostic benefit. So add atenolol. Okay. So, all right. This is the last question from this particular section. Then I will move to the new topic. Let's see. Dr. Fairuz, can you take this question?
A 54-year-old man with atypical chest pain is referred to cardiology. An exercise ECG shows non-specific ST and T-wave changes. Following this, an coronary angiogram is performed, which demonstrates no evidence of atherosclerosis. A diagnosis of Prinzmetal's angina is suspected. What is the most appropriate first-line treatment?
So Prinzmetal angina is basically there is vasospasm. So you need to like work on the vasospasm.
Blocker.
So what's your answer?
Felodipine may be the answer.
Okay, yes, very good. Yes, calcium channel blocker is the first line treatment to prevent or like relieve the vasospasm in Prinzmetal angina. All right. So I think you all will get full marks in terms of answering the ischemic heart disease related question. Just go through the I will also discuss about each of these medications prognostic value when I'm discussing about the heart failure at the same time. Okay, now in terms of the chest pain, assessment of patients with suspected cardiac chest pain. So anginal chest pain, how you can define the anginal chest pain. So number one is constricting discomfort in front of the chest, neck, shoulders, jaw, arm, precipitated by physical exertion, relieved by rest or GTN in about 5 minutes. Patients with all three features have typical angina. 2 of the above features have atypical angina. Patients with 1 or none of the above features have non-anginal chest pain. However, even if you do consider the patient might be having non-anginal chest pain, you should always give ECG to the patient. Never, in my practical experience, I have seen that never discard a patient coming to your chamber or your outpatient department complaining of chest pain without doing an ECG. Even if the age is not suggestive, even if you know that the patient might be having like some form of HCR, still always go for an ECG. Better to be safe than sorry. So in patients, stable angina cannot be excluded. In that case, we go for further investigations. So first line is CT coronary angiography. So this is a non-invasive test, particularly for calcium scoring or for assessment of the atherosclerotic changes. This is a good investigation. Second line is a non-invasive functional imaging. For example, myocardial perfusion scan or myocardial W-vitamin stress test, or a layman term is stress echocardiography. So in normal echocardiography, we just check for the patient's ventricular ejection fraction and the chamber and the valves, etc. In case of the functional imaging, what happens is like we give a dose of the W-vitamin, which acts as a inotropic agent. Okay, it increases the force of contraction at the same time cardiac output. So in areas where the blood supply is cut off, like that can be properly visualized, because if after giving W-vitamin, that is immobile or adynamic, that can be easily picked up in the echocardiograph. And third line is actually going for invasive coronary angiography or coronary angiogram. So before, as this is an invasive procedure, there are lots of complications related to it, unless the patient has like absolute indication, considering the risk-benefit ratio, there is always, if you have window for going for non-invasive measures, go for that. But if you think that the patient absolutely requires coronary angiogram and there is a possibility of giving stent at the same time, in that case, preferable investigation is always the coronary angiogram. So there are not only the one that I've already mentioned, but there are several other examples of the non-invasive functional imaging. For example, myocardial perfusion scintigraphy. This is also very similar to the SP-CT scan or the PET scan that we do for checking the metastasis in body. Stress echocardiography or first pass contrast enhanced magnetic resonance, MR perfusion. This is very advanced, not done in routinely. MR imaging for stress-induced wall motion abnormality. These two are actually done for research purpose. Rather, myocardial perfusion scan and stress echocardiography, these are more commonly done in routine day-to-day clinics. So, all right. Let's try to solve some question. Question number 186, Dr. Zafria Piada. Dr. Piada, can you take this one?
Yes, ma'am. A 52-year-old female with an acute presentation of chest pain undergoes an angiogram to look for coronary artery disease. During the procedure, she was run of ventricular tachycardia, which self-resolves. The report of angiogram revealed normal coronary arteries. All other cardiac investigations were normal. What is most likely follow-up plan? Insert internal cardiac defibrillator, perform an exercise stress test, discharge from cardiology when medically fit, commence amiodarone, repeat the angiogram. Ventricular tachycardia. Commence amiodarone.
Okay, but it has already resolved. In that case, would you like to give the amiodarone to the patient, because amiodarone can cause lots of complication later on? Here you can see that patient, yes, option C is the answer. Why? Because patient has this kind of ventricular tachycardia, which is procedure induced. So if there is any procedural complication or procedural arrhythmia and it somehow resolves after completion of the procedure, you should not start with any antiarrhythmic drug for a long term, because in starting a long-term amiodarone will cause more harm than good for the patient. All right. So this is actually a single event that was taking place during the procedure. All right. Thank you. Okay, question 188. Dr. Shafi Ahmed Hina, can you take question 188, please? In that case, Dr. Tan Sing Ying.
Yes, ma'am. A 65-year-old woman complained of chest pain and exertion such as when walking up the stair or doing housework. She described the pain as constricting discomfort in front of the chest. The pain typically radiates to the left shoulder and disappearing on resting. She suffered from severe osteoarthritis of the left knee, which limit her mobility. She also suffered from brittle asthma and high blood pressure. Her last cholesterol check was 4 years ago, and this was normal. She is a non-smoker. On examination, she appeared well and pain-free. Her sound were normal with no murmur. Resting ECG is normal. What is the next step in the investigation of this lady's symptom? A. Check her cholesterol level to determine the investigation of choice. B. Exercise stress echocardiogram. C. Contrast enhanced coronary CT angiography. D. Adenosine stress cardiac MRI. E. Invasive coronary angiography. Since patient have a OA, cannot go for exercise stress test, I think the choice should be contrast enhanced coronary CT angiography.
Okay, all right. Yes, very good. Because patient is having significant osteoarthritis. Okay, and that's why exercise test is not a good option for this patient. At the same time, checking the cholesterol level will only help her with whether we start with the statin or not. But this is not the diagnostic clue. It will not give us diagnostic clue regarding the angina or the chest pain. So in the adenosine stress CMR, this is actually done for like cardiomyopathies or like research purposes. So this is not the ideal test to do here. And invasive coronary angiography, we could have considered that if the ECG was abnormal. So in that case, as the ECG is normal, so that's why we do not go for something invasive. Plus the patient has nothing, like the gray scoring will be quite low for this patient as well. So contrast enhanced coronary CT angiography is the ideal choice here. Thank you. All right. I've already discussed about the thrombolysis. Just like go through the examples and what are the absolute contraindication. Side effects are basically hemorrhage, hypertension, and allergic reaction, mainly done, which can happen in streptokinase. So even in settings like in Bangladesh, not sure about how it happens in other countries. So in government hospital particularly, we do what we have. We can do with whatever we are like supplied with. So streptokinase, of course, we have to consider to giving lots of patients because PCI is not possible. We only have like 2 PCIs can take place in a tertiary center here at the same time. So imagine if we get like 10 to 20 like really bad MI patient. So we cannot go for primary PCI right away for those patients. We have to keep them under observation. So during that meanwhile, if we are going for like thrombolysis or fibrinolysis and streptokinase is the choice of drug, in that case, we make sure that the patient is well hydrated, and we are already take hydrocortisone and chlorpheniramine in one hand, and then we mix the streptokinase powder with the normal saline and give it very slowly so that allergic reaction does not take place. And renal impairment is another common complication that can arise, particularly if the patient has already some form of renal impairment previously. So in that case, monitoring the fluid intake output chart, like urinary catheterization, at the same time, proper hydration of the patient, these are very important. So it's a good thing that in most of the private center and in the higher centers or in countries outside of the Bangladesh, they do not have to face problems like this. Okay, in terms of post-MI patients, so secondary prevention. In that case, all patients should be offered with the following drug, that is ACE inhibitor, beta blocker, aspirin, and statin, no less. If the patient is, for example, having any complete contraindication to beta blocker, in that case, you can opt for other medications like rate-limiting calcium channel blocker or ivabradine if the patient is having sinus rhythm. But all the patients should be having aspirin, lipid-lowering agent, ACE inhibitor, and beta blocker. Dietary advice, we already know, like particular importance is omega-3 fatty acid supplements, particularly cod liver oil or sea fish consumption that should be advised to the patient. Completely cessation of the smoking, alcohol intake should be moderately reduced. Exercise, cardiac friendly 20 to 30 minutes. Nowadays, it says the 45 minutes of exercise every 3 to 4 days a week. This is particularly useful. Sexual activity, okay, may resume 4 weeks after an uncomplicated MI, but be very, very careful in terms of prescribing any sildenafil or phosphodiesterase 5 inhibitors. If given along with GTN, it can cause significant vasodilatation, which can complicate the patient's condition really, really bad. Okay, this should be avoided in patients with prescribed either nitrates or nicorandil. All right. Clopidogrel, okay, that these clopidogrel should be continued for 1 year. But then again, it also depends on a couple of other things as well. For example, like the gray scoring, we can do gray scoring again. If the scoring is really high, in that case, we can continue aspirin clopidogrel combination beyond that 1 year as well. However, normally in general, like right after the MI event has taken place, dual antiplatelets are continued for 1 year and then only a single antiplatelet. We prefer aspirin over clopidogrel. But in case of the stroke, transient ischemic attack, or peripheral vascular disease, clopidogrel is considered to be superior to aspirin. Okay, aldosterone antagonist. So patients like ACE inhibitor, angiotensin receptor blocker, these are particularly important. If the patient is having any concomitant heart failure, in that case, spironolactone can be considered. Okay, question number 190. Doctor, who haven't participated yet, Dr. Nishakanta, I think. Dr. Nishakanta, can you take this?
Yes, ma'am. A 65-year-old man is discharged from hospital following a thrombolyzed ST elevation myocardial infarction. Other than a history of depression, he has no past medical history of note. Examination of his cardiorespiratory system today was normal. His stay on the second coronary care unit was complicated by the development of dyspnea, and an echo shows a reduced left ventricular ejection fraction. Other than the standard treatment with an ACE inhibitor, beta blocker, aspirin, and clopidogrel, statin, what other type of drug should he be taking? Angiotensin 2 receptor antagonist, potassium channel activator, aldosterone antagonist, thiazide diuretic, loop diuretics. The answer is C, aldosterone antagonist.
Okay, very good. Because out of all these things, patient ACE inhibitor, ARB, they do have prognostic value, but patient is already on ACE inhibitor. So this type of combination are not particularly encouraged. That can lead to significant hyperkalemia. On the other hand, aldosterone antagonist, that has prognostic benefit. All right, very good. Sometimes mechanism of action can come, but this is particularly, like under the pharmacology umbrella, especially mechanism of clopidogrel. This is quite important. Fondaparinux, bivalirudin, abciximab, or glycoprotein 2B3 receptor antagonist. In our country, I have seen that in lots of hospitals, they have already started preferring ticagrelol over clopidogrel. So a lot of things are actually like changing. Nowadays, only the traditional management is not followed anymore. Okay, let's try to solve this question. 198. Anyone who's willing, you can take this. A patient admitted with central chest pain, diagnosis of non-ST elevated MI is made. Aspirin, fondaparinux are already given. What is the mechanism of action of the fondaparinux?
It activates antithrombin 3.
It activates antithrombin 3. Okay. All right. Fondaparinux is a similar way to the low molecular weight heparin. All right. So these are a little bit questions that requires you to, like memorize the stored information. Nothing to think about. But then again, you also have to remember that you need to like pass the exam. So it's not like these topics are less valuable or anything. As long as you can answer lots of questions at the same time and score marks that will help you pass, you're good to go. All right, let's try to solve question number 200. 50-year-old man admitted to the resus with a suspected anterior MI, and ECG on arrival confirms the diagnosis, and thrombolysis is prepared. Patient is stable and pain is well controlled with IV morphine. Clinical examination shows blood pressure normal, 140/84. Pulse is okay. Oxygen saturation on room air is 97%. So what is the most appropriate management with regards to oxygen therapy? I think everybody can get the answer right.
B.
Yes.
B.
No oxygen therapy is required. Very good. So poor prognostic factors, just go through this very briefly. Of course, increasing age and development of heart failure concomitant at the same time. If there is any peripheral vascular disease, the patient is having cardiogenic shock-like features, like if the pressure is less than 90/60, Philip classification and initial serum creatinine concentration is high, elevated initial cardiac markers and ST segment deviation or dynamic ST changes, cardiac arrest on admission. So these are all poor prognostic factors. Philip classification is for, like risk stratification for myocardial infarction patients. So there are 4 classification, no signs of heart failure. So patient is having 30-day mortality only 6%. But when the patient is in cardiogenic shock or pulmonary edema, you can see that the mortality rate goes from 38% to 81%. Cholesterol embolization. This is again rather underrated, but an important topic for part 1 examination. So cholesterol embolization, you will see that it will take place after like performing a coronary angiogram or any invasive procedure. Cholesterol emboli may break off, causing renal disease, seen more commonly in arteriopaths, abdominal aortic aneurysm. So after this procedure, what happens is like in an infarct area, like the stent was inserted or maybe, like angiogram was taken place. So those emboli can be dislodged and microemboli are formed, which can, with the help of circulation, go into the renal vasculature and cause subsequent complications. So features of cholesterol embolization is eosinophilia. So in the peripheral blood film, you'll see eosinophilia, and the eosinophil differential count can also be increased in the total blood count. Purpura or rash, livedo reticularis, and renal failure. These are the common features of cholesterol embolization. In this particular scenario, you can see question number 207. Background of ischemic heart disease, peripheral artery disease. So that's a risk factor already. Presence to the emergency department, feeling generally unwell for the past 2 days with fever, myalgia, but nothing. But this morning developed a purple cold left middle toe. So there is a sudden onset gangrene. On examination, there are signs of early ischemia to the toe and a faint livedo reticularis rash is seen on the foot. A diagnosis of cholesterol embolization is suspected. So supportive for this diagnosis is basically eosinophilia. In this scenario, you can see that elective abdominal aortic aneurysm repair. So past history of log-standing asthma and undiagnosed peripheral neuropathy. On day 4 post-op, she develops a net-like rash over the torso with fever, myalgia, and discoloration of her toes. Her blood tests are, you can see eosinophil count is erased here, and rest of the parameters actually creatinine and urea is increased. So this is slightly diagnosis is cholesterol emboli. Dresses, there has to be like some form of drug abuse or, like culprit drug in the background. So dress is basically drug reaction, eosinophilic systemic syndrome. So there is no mention of a drug. So DRESS syndrome actually presents in a very similar manner to the cholesterol embolization. That's why I've discussed this, because there is no mention of a sulfur-containing drug here. So the answer will not be the DRESS syndrome. For Sharp-Strauss actually presenting in this particular age, it's very, very unlikely. 72-year, it's very unlikely. Usually young adult patient with asthma, and after starting glucotriene receptor antagonist, patient symptom has worsened. And that can be, like conclusive for Sharp-Strauss. Age is not suggestive here. So the complications of myocardial infarction, most common complication that you can divide up the complications into 2 different parts. One is the acute complication and the chronic complication. In acute complication, cardiac arrest, cardiogenic shock, cardiac arrhythmia, acute left ventricular failure, or some mechanical cardiac complications. Those are some common complications that can arise acutely. Echo hচ্ছে Hello. Sorry, there was some technical problem. There was some sort of echoing that was coming. Anyway, so cardiac arrest mainly takes place due to if there is any malignant arrhythmia, for example, ventricular tachycardia, ventricular fibrillation, that can potentially cause cardiac arrest. Cardiogenic shock due to low perfusion, loss of cardiac output, subsequently, blood pressure is also reduced and the patient is tachycardic and going into cardiogenic shock. So cardiogenic shock is nothing but, loss of cardiac output resulting in poor tissue perfusion. Chronic heart failure, this is one of the chronic complications, tachyarrhythmia, bradyarrhythmia. Particularly bradyarrhythmia is more common in inferior MI. So pericarditis, that can also take place within 2 to 3 hours, within 48 to 72 hours following a transmural MI. So within 2 to 3 days, if the patient presents with chest pain, you should consider pericarditis as part of the complication. But if the patient comes with a similar, complication, like patient is complaining of chest pain, shortness of breath, but there is a history of MI attack 2 to 3 weeks back, in that case, most likely the diagnosis is Dressler syndrome. Okay, so pain typically, pericardial rub may be present, and effusion, which can be evidence like low voltage ECG, evidence of pulses alternance. So pulses alternance is basically in the ECG, you'll see that the height of the R wave actually differ, in one lead, you'll see like a type of R, height of the R wave is like, okay, if instead of talking, I think it's better to just draw. Pulses alternance means that height of the R wave is different, like this. Although it looks a little bit like atrial fibrillation, just imagine the sinus rhythm, this is in sinus rhythm, but height of the R wave is actually different or variable. This is known as pulses alternance. Left ventricular aneurysm, this is again another common complication that can arise, particularly if the left ventricular myocardium is mainly affected. Transmural necrosis is taken place. There is aneurysm formation. How we can consider left ventricular aneurysm? There will be persistent ST elevation even after guideline-directed medical therapy or even after thrombolysis. If you still see that there is persistent ST elevation in the subsequent ECG, that is very much suggestive of left ventricular aneurysm, and you can confirm it by doing an echocardiography. They have high risk of thromboembolism, so that's why patients should be anticoagulated as soon as possible. And mechanical complications will include left ventricular free wall rupture, VSD, functional mitral regurgitation, or acute mitral regurgitation, or rupture of the chorda tendon or papillary muscle. These are all some of the common complications. So here you can see a 65-year-old man with no significant past medical history admitted to the emergency department. ECG is consistent with anterior MI. Unfortunately, he develops cardiac arrest shortly after arriving in the department. And what is the most common cause of death in patients following a myocardial infarction? Is it complete heart block, ventricular fibrillation, papillary muscle rupture, cardiogenic shock, or pulmonary embolism? So malignant arrhythmia is the main cause, culprit here, ventricular fibrillation. Does anyone know what Dressler syndrome is?
Post-myocardial infarction complication. Eosinophilia, pericarditis, and
Okay.
pulmonitis, maybe.
So this is the fraction of
Eosinophilia.
5P, okay? Pain, pyrexia, pleural effusion, pericardial effusion, and pleurisy. So after this is an antigen antibody mediated or antibody mediated reaction, okay? So it usually takes couple of time to develop this antigen antibody reaction. Perhaps 2 to 3 weeks is the optimal time to develop this antibody mediated reaction. This is Dressler syndrome, but pericarditis usually takes place. Why am I focusing so much on the differences between pericarditis and Dressler syndrome? Because the only way to differentiate pericarditis from Dressler syndrome is the duration. So within 2 to 3 days, pericarditis takes place, and 2 to 3 weeks, Dressler syndrome takes place. Pericarditis can take place as a part of MI complication directly due to involvement or inflammation to the adjacent pericardium. But Dressler syndrome takes place due to antigen antibody formation. That's the main difference. In pericarditis, if the patient is not having any cardiac tamponade feature, in that case, just keep the patient under observation, give some, like painkillers and steroid. These are the main modality of treatment. In case of Dressler syndrome, steroid is the main modality of treatment. Okay. So let's try to answer this question from the management section. 78-year-old man in the surgical ward 3 days post-op following a colectomy, recently diagnosed with colon cancer and has a history of polymyalgia rheumatica. Current medications include cocodamol 30/500, prednisolone, and prophylactic dose of low molecular weight heparin. 5 minutes ago, he started to complain of severe central chest pain. ECG performed by the nurses show ST elevation in the anterior leads. Aspirin and oxygen have been given by the foundation ward doctor. What is the most appropriate treatment? Is it option A, IV diamorphine, increase the low molecular weight heparin to treatment dose, double his prednisolone dose, B, IV diamorphine, plus arrange an echocardiogram urgently to exclude pericardial tamponade. Option C, IV diamorphine and call the family to discuss withdrawal of the treatment. D, IV diamorphine and arrange a percutaneous coronary intervention. And E, IV diamorphine plus thrombolysis. Which one is it? It's quite straightforward.
D, I think.
Percutaneous coronary intervention, yes. Because there is ST elevated MI, so no need to wait for further. Just try to, since the patient is already admitted in the hospital setting, go for the PC as soon as possible. Okay. All right, question number 217. A 71-year-old man reviewed in the coronary care unit, admitted with an anterior ST elevation, MI, received thrombolysis in altiplase. 90 minutes following this, an ECG shows 30 to 40% resolution in the ST elevation. So what is the most appropriate management? Percutaneous coronary intervention, repeat ECG in 4 hours. If still not 50% resolution in ST elevation, then proceed to percutaneous coronary intervention. Repeat thrombolysis with altiplase, start a nitrate infusion, inform his relatives that further intervention is futile, and ensure adequate pain relief is okay. I think you have already seen the answer. The thing is, you have to go for within the first hour. There is it should be more than 50% resolution in the ST elevation. If not, go for rescue PCI. So the answer is go for percutaneous coronary intervention. I think they have given the answer here wrongly. This will be A. So some common complication that may arise from the PCI strategy is that stent thrombosis or restenosis. So stent thrombosis or due to platelet aggregation and occurs only in a very minor individual, rather than stent thrombosis, ISR, also known as in-stent restenosis. This is more common, and which occurs due to excessive tissue proliferation around the stent. So imagine this is a blood vessel. So imagine this is where the clot formation has taken place. Now you have put a stent up to adequate size here. So now after putting the stent, you have facilitated the blood supply here and dislodged the infarct. But because of this stent insertion, there is excessive, like tissue proliferation around the stent, which can cause further restenosis. This is a more common phenomenon because reinfarct or instant thrombosis, it was a common phenomenon before there was, like discovery of drug-eluting stent. So most of the metallic stent was morely associated with thrombosis, bare metal. But restenosis is a more common phenomenon, particularly if the patient has diabetes or chronic kidney disease. In that case, this is more common, this instant restenosis ISR phenomenon. Risk factors include diabetes, renal impairment, and stents in venous bypass graft. Types are bare metal stent and drug-eluting stent. These are superior in comparison to the bare metal strength. DVLA, it's quite an important topic, especially for cardiogenic syncope or cardiac syncope or post-MI patients. What happens to them if they want to or decide to go for driving? Mainly here you can see, like if a patient has gone for angioplasty elective, then 1 week of driving, then he can resume driving again after that 1 week. If the patient has more extensive operation like open heart surgery or coronary bypass, coronary artery bypass grafting, then 1 month bed rest is required, and then after that, patient can resume driving after the 4 weeks. In case of acute coronary syndrome, 4 weeks of driving and 1 week if successfully treated by angioplasty. And if a patient is having pacemaker insertion, then after that, 1 week later, the patient can resume driving. More important is here, in this case, implantable cardioverter defibrillator. This is the most important one. Usually, implantable cardioverter defibrillator is given to patients who have already sustained an episode of ventricular tachycardia. Like it could be due to familial syndrome or it could be due to a post-MI complication. So driving is ceased for 6 months. And if implanted prophylactically, then cease the driving for 1 month. In which patient we give prophylactic ICD? In certain genetic condition where the patient is more prone to developing cardiac syncope. In those patients, if we give ICD as a prophylaxis rather than, okay, how to simplify this information. There is a genetic condition in the heart known as hypertrophic obstructive cardiomyopathy or HOCM. So definitive treatment for this condition is ICD or implantable cardioverter defibrillator. So normally in HOCM patient, if they have already sustained VT, for example, and now you place the ICD, in that case, 6 month driving should be off. However, patient has not had VT yet, but you have diagnosed the patient at an early stage. The patient is having HOCM. So he will definitely have a risk for developing VT at some point in his life. So you give the patient ICD as a prophylactic basis. In that case, driving should be stopped for 1 month. In heart transplant patient, DVLA does not need to be notified here. And if this is a case of aortic aneurysm, large aortic aneurysm that is 6 centimeter or more, then notify the DVLA. Licensing will be permitted subject to annual review, and aortic diameter of 6.5 centimeter or more disqualifies the patient from driving. Pacemaker and ICD, these are important for DVLA guideline. Okay, I will discuss cardiac catheterization in the next class, not this one. I will take we are actually done with ischemic heart disease and coronary syndrome basically so far. Next topic, I will go through the cardiac arrhythmia. I will take roughly 5 minutes of break. Then I will start again at 5:30, okay? Okay, so now we are actually going to be discussing about another important topic from cardiology section that we have to practice not only the stable cases, but also the cardiac emergency cases as well. So that's why we will focus on the heart failure now. So heart failure is basically loss of cardiac output again, when the heart is not able to pump properly the blood and not able to maintain the oxygenation in the tissue level. So that is known as the heart failure. So heart failure is actually broadly, it is divided into depending on what time the patient has been presented with the features of heart failure. Depending on that, it's mainly divided into 2 categories, that is acute versus chronic heart failure, also known as acute versus stable heart failure. However, you can remember it, up to you, most commonly known as acute versus chronic heart failure. And depending on the presentation, as the presentation is quite varied when the right or the left side of the heart is involved. Further classification is right heart failure versus left heart failure. And when both sides of the heart failure takes place, that is known as biventricular failure or congestive cardiac failure. Nowadays, according to the American Heart Association and the NYHA classification, so nowadays, based on the ejection fraction, there are further some categories. So only based on the ejection fraction, there are 4 categories. One is left ventricular with reduced ejection fraction, with mildly reduced ejection fraction, with preserved ejection fraction, and the other one is basically mild to moderate reduced ejection fraction. So, but that is again a very high level, like discussion. We will not focus on that here. In terms of acute left heart failure, so this is a medical emergency, which is why I will discuss it first and then the later part of the heart failure section. So in terms of acute heart failure, you have to consider taking history. This is very important. Of course, always any emergency situation start with ABCD resuscitation or assessment. Check the airway, oxygen saturation, vitals, breathing, circulation, disability status, and exposure. After that, establish an IV access, sit the patient in propped up position, and give patient high flow oxygen unless contraindicated. For example, if a patient is suffering from COPD or chronic obstructive pulmonary disease, in that case, you cannot give high flow oxygen for obvious reason. But most of the time, these type of patients, because there is lack of tissue oxygenation, so you have to give the patient high flow oxygen here. So important management is propped up position, high flow oxygen, open IV access, then send ECG, NT-proBNP, echocardiogram, chest X-ray PA view, full blood count, RBS. This important investigation simultaneously. Give diamorphine, IV. However, you have to be cautious if the patient is having COPD or liver failure, because in these particular conditions, like in COPD, it can cause cardiorespiratory depression and cause, in severe COPD in particularly, diamorphine is best avoided. This will help in reducing the chest pain. At the same time, will help if a patient is distressed or agitated, diamorphine will actually provide symptomatic relief here. So important treatment is basically GTN. So start with, like sublingual tablets, 2 tablets, 0.3 milligram, or you can give GTN spray underneath the tongue as well. And most important being the loop diuretics, that is furosemide. You can start with 40 to 80 milligram given via IV and increase the dose up to the patient's ongoing treatment. However, if the patient is having high blood pressure, so most of the time acute left ventricular failure common causes either malignant hypertension or because if there is a background of myocardial infarction. So if the patient is having very high blood pressure, in that case, like if the SBP is more than 100 millimeter mercury, in that case, you can give IV GTN as well, IV isosorbide infusion. But continuous systolic blood pressure monitoring is required here. So it should always be more than 90 millimeter mercury after starting with the IV GTN. Never less than that, because in that way, patient might be going into cardiogenic shock. Next up is you have to keep the patients under monitoring and check for the vitals at the same time. If the patient is still refractory, in that case, you can increase the dose of the loop diuretics. Okay. And you can also consider some additional measures such as continuous positive airway pressure or CPAP. So what it does in acute heart failure, we know that there is fluid accumulation within the lungs, like within the alveoli, in the interstitium, right? So in CPAP, it actually helps driving this fluid back into the capillary, okay? So thereby the alveoli that was collapsed due to this increased, like fluid collection within the interstitium, they will be able to, collapse or maybe, like inflate properly. So in order to drive the fluid out from the interstitium into the alveolar capillary, CPAP can be given and it will provide quite a good benefit, like symptomatic relief to the patient. If the patient is still being refractory, in that case, treat it as a case of cardiogenic shock and refer the patient to ICU. And in the ICU, sometimes they usually start with intra-aortic balloon pump here. Intra-aortic balloon pump to increase the cardiac motility. So these are basically the steps of management. You just only have to focus till the point of CPAP or, like mainly IV diuretic, morphine, GTN, high flow oxygen, propped up position, increase the diuretic dose. You can give IV GTN as well, as long as the blood pressure is more than 100. And you can consider CPAP before sending the patient to, with a consultation of respiratory physician in the general ward even. And if the patient is still refractory, in that case, refer the patient to the ICU and treat it as a case of cardiogenic shock. This is the treatment algorithm for acute left ventricular failure management. Now, we will discuss on the chronic heart failure. All right. So chronic heart failure patients, there are particular medications which have significant prognostic value. So for example, one of the most important being spironolactone or aldosterone receptor antagonist. Another one is eplerenone. Some centers give eplerenone as well. But do remember that thiazide diuretics and loop diuretics, they do not have any, they only provide symptomatic benefit. They're, used in the acute management, but they do, in the long run, furosemide or thiazide diuretics, they do not have any prognostic benefit or value. Number 2 is ACE inhibitors or ARB or angiotensin receptor blockers, because they help in reducing the afterload. Okay, and number 3 is, this is a relatively new medication. So this is a combination of angiotensin receptor blocker plus neprilysin inhibitor. This is also known as ARNI. ARNI is a very similar group to this ACE inhibitor ARB because it has combination angiotensin receptor blocker and neprilysin inhibitor. So in order to understand how does a neprilysin inhibitor work, I just have to draw a diagram, I think. Okay. So BNP or brain-derived natriuretic peptide, ANP, atrial natriuretic peptide. So these are some peptides that are released from the myocardial stretching. If the myocardium is under, so these are naturally occurring peptides that are released when the myocardium is under some sort of stress, angina, or any type of, under any stress condition, these peptides are naturally synthesized. And what they do is they have a little bit of natriuretic property. So natriuretic property, by that I mean, they help in, salt and water excretion through the renal tubules. So pro-BNP, on the other hand, so this BNP is actually released as a pro-peptide. This is known as the pro-BNP. And pro-BNP is further divided into BNP and N-terminal pro-BNP fragment. So this actually, that's why you will see in heart failure patient, NT-proBNP is usually measured to see the heart failure, not only as a part of diagnosis, but at the same time to see the therapeutic monitoring as well as prognosis of the heart failure patients. So this cleavage is, this cleavage of the pro-BNP is done in the presence of a particular enzyme known as neprilysin. So the neprilysin is actually good for the body because with the neprilysin enzyme, when the pro-BNP is cleaved into BNP, and this BNP helps get rid of excessive salt and water retention in the body. So they cause natural diuresis in the body. They act as natural diuretics. So we do not want the neprilysin to be working during a heart failure event. So that's why neprilysin inhibitors are used in the management of heart failure. So this medication also has significant, prognostic benefit. One example of neprilysin inhibitor is the sacubitril. Sacubitril plus valsartan combination. This is the common combination that is currently under the market. Number 4 is beta blocker. Very, very important drug. Beta blocker not only helps in reducing the, heart rate, but at the same time, it helps in restoration of the sinus rhythm, reduces the preload and the afterload at the same time. So that's why beta blocker is a very important drug for prognostic benefit in heart failure patient. Number 5 is ivabradine, like I've already mentioned. If you cannot prescribe beta blocker, in that case, you can go for ivabradine. On the other hand, remember that calcium channel blockers, they do not have any prognostic benefit in heart failure management. Important drug for prognostic benefit is the statin. Very important. So any patients with heart failure and high, secondary, as part of secondary as well as primary prevention, statin should be co-prescribed because it reduces mortality in the long run. So these are the particularly main drug like spironolactone, ACE inhibitor, ARB, and ARB plus nephrolysin inhibitor combination, beta blocker or ivabradine, and statin. Now, I would like to focus on 2 more drugs that also provides significant prognostic benefit. Number 7 is SGLT2 inhibitor, also known as empagliflozin or dapagliflozin. Empagliflozin, this is anti-diabetic medication, I know, because it helps in osmotic diuresis. But in non-diabetic patients who are having heart failure, particularly even if the ejection fraction is not that significantly reduced, in those patients, American Heart Association suggests that it provides cardiovascular, prognostic benefit. It's cardio-friendly. So that's why in those patients, empagliflozin should be started. And number 8 is a combination drug, which is basically nitrate and GT. Sorry. Okay, I will just use another page. So GTN plus vasodilator combination, because GTN helps in reducing the helps in venodilatation, thereby reducing the preload mainly. And vasodilators, centrally acting vasodilators such as hydralazine, they help in reducing the afterload mainly. So separately, a centrally acting vasodilator such as hydralazine, nitroprusside, they do not have any prognostic benefit. Neither does the GTN. However, if these 2 drugs are used in combination, in that case, they do provide prognostic benefits. So GTN plus hydralazine combination, this is another medication that can be used in the long run. So again, I'm going to the list of the medication that I've already mentioned, like drugs that should be used in chronic management of heart failure, which provide prognostic benefit. Spironolactone. Note that there is no role of thiazide or loop diuretics. ACE inhibitor, ARB, or angiotensin receptor blocker in combination with nephrolysin inhibitor. They provide significant prognostic benefit. Beta blocker, ivabradine. But note that calcium channel blocker does not provide any, prognostic benefit. Statins and SGLT2 inhibitor plus this other medication, that is GTN and vasodilator in combination, not separately. So these are the medication that should be used in chronic heart failure patients. Now, the other classification that I was talking about is that left heart failure and right heart failure. So in general, when the left side of the heart is basically impaired, that is known as the left heart failure, features are mainly due to pulmonary congestion. So in these kind of patients, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, leg edema, lung crepitations, these are more common, okay? And in case of the right heart failure, there is systemic congestion. Right side of the heart is affected. So as the superior and the inferior vena cava drains into the right side of the heart. So that's why systemic congestion is mainly happening in case of right heart failure, which is why you will see the patients will be having raised JVP, ascites, then dependent edema, tender hepatomegaly, and nausea, vomiting due to intestinal edema. So this is the basic main difference, just on the basis of, parts of the heart that is involved and the way of presentation. But in terms of management, there is no difference at all. So left heart failure resulting in pulmonary congestion and right heart failure resulting in systemic congestion. So what is biventricular failure or congestive cardiac failure? So when both the left heart failure and right heart failure takes place at the same time. So most common culprit is behind a massive MI, massive myocardial infarction, or dilated cardiomyopathy. These are the main causes. In terms of left heart failure, what's the main cause? Mainly heart problem, such as MI or ischemic heart disease, then valvular heart disease, cardiomyopathies. So these are the common causes of left heart failure. And for the right heart failure, common causes are lung diseases, such as pulmonary embolism, asthma, COPD, interstitial lung disease, bronchiectasis, all leading to corpus pulmonale basically, and thereby affecting the right side of the heart. So these are the main differences between left side and right side and heart failure and biventricular failure. Now there is another terminology, which is as this is quite new concept, not for exam purpose, but for knowledge purpose, you should be acquainted with this. That is classification of heart failure on the basis of ejection fraction. So normally, number one is reduced ejection fraction. So if the left ventricular ejection fraction is less than 40%. So this is the first classification. Number two is, it is left ventricular mildly reduced ejection fraction. So when the ejection fraction is within 41 to 50%. And number three is preserved ejection fraction. So here the ejection fraction is more than 40%, but there is a separate type of scoring is used. This scoring, you don't have to know that. But in this scoring, there is high risk for heart failure. Mainly previously, this preserved ejection fraction was known as diastolic heart failure. So, okay. So based on this ejection fraction, main important point is preserved ejection fraction. If there is a high risk for heart failure, but the ejection fraction is more than 40%, mildly reduced is within 41 to 50%, and reduced ejection fraction is less than 40%. And from the history, so from the clinical examination, what are the things that we examine in a patient with heart failure? So imagine this is a patient with heart failure. So in that case, you have to check for the oxygen saturation. Number two is you have to check for the vitals, blood pressure, pulse, or the respiratory rate, temperature. You have to check for, in the neck, the edema. In the eye, always check for anemia, jaundice, because in right heart failure, there might be evidence of, as a part of liver congestion, there might be jaundice taking place. Anemia is an important risk factor for heart failure. That's why anemia should be assessed. Cyanosis, you should always check that because of lack of tissue oxygenation, patient might be central cyanosis. Okay. And in the neck, you have already checked the JVP as well as check for the thyroid gland as well, because thyrotoxicosis can also precipitate heart failure. Next up, you have to check for the patient's heart, auscultate the heart if there is any evidence of first and second heart sound as well as any evidence of murmur. And then you have to auscultate for the lungs, particularly the base of the lungs, if you can listen to any crepitation. In the abdomen, look for if there is any ascites and if there is any hepatomegaly, tender hepatomegaly. And scrotal edema might be taking place in case of male patients. Sacral edema might be present in patients who are lying down position. And leg edema should be assessed as part of both left and right heart failure. So these are some common examination steps for any patients with heart failure. Next up, and of course, you have to check for pulmonary hypertension, like if there is any loud P2 or, like left parasternal heave and something like that as well. Feature of cor pulmonale. All right. Next up is in terms of management, as I've already mentioned, the management of acute and chronic heart failure. There is nothing more to know about here. Just try to know about some of the complications of heart failure. So some of the commonest complications of heart failure is basically when the heart and kidneys, these are interconnected. So when there is heart failure, this might lead to inadequate perfusion to the kidneys, thereby leading to kidney failure or kidney injury. So renal impairment is a common complication. And number 2 is electrolyte imbalance. So chronic heart failure itself can cause hyponatremia, and it can also cause both hypo and hyperkalemia actually. So why hyperkalemia? Because of the drugs. For example, ACE inhibitor ARB, they can lead to hyperkalemia, and hypokalemia can take place because of, again, because of the result of the loop diuretics and loop diuretics and ACE inhibitor ARBs, and the hyperkalemia can take place because of the spironolactone mainly, or because of the acute kidney injury. So this can lead to hyperkalemia and hypokalemia due to the diuretics mainly. Mainly the result of diuretics. Electrolyte imbalance. And of course, heart failure itself is a risk factor for thromboembolism. Then arrhythmia, sudden cardiac death. So these are some of the complications that are related to heart failure: renal impairment, electrolyte imbalance, thromboembolism, arrhythmia, and sudden cardiac death. So as part of the general, approach for any chronic heart failure patients, if the patient is having any concurrent arrhythmia, so remember that if iron deficiency is not corrected in any chronic heart failure, that can result in recurrent hospital admission and even significant morbidity and mortality in chronic heart failure patients. So that's why iron should be checked, like serum ferritin level should be checked, and if there is an iron deficiency, that should be corrected. And patients should be these are immunocompromised patients, which is why vaccination is very important. That's why annual influenza vaccines are given, and pneumococcal vaccine as well. Digoxin, okay. In terms of digoxin, there is some controversy because in valvular heart disease, if the patient is having concomitant heart failure, you can go for digoxin. However, it does provide symptomatic relief, but there is no prognostic value of digoxin, as well as in elderly population. Using digoxin can be very tricky because it is associated with both liver and kidney impairments and electrolyte imbalance. So before giving digoxin, if there is any concurrent hypokalemia, hypomagnesemia, or hypocalcemia, that should be corrected. Let's try to solve some questions here. Then I will move to cardiac arrhythmia. All right, question 256. A 62-year-old man who has recently been discharged from hospital in Hungary following a myocardial infarction. He brings a copy of an echocardiogram report which shows left ventricular ejection fraction is 38%. So that is reduced ejection fraction. On examination, his pulse is 78 per minute, regular, blood pressure is normal, and his chest is clear. His current medications include aspirin, simvastatin, and lisinopril. So what is the most appropriate next step in terms of his management? Add atenolol, add furosemide, add bisoprolol, add isosorbate mononitrate, make no changes. Which one is the answer?
Add bisoprolol.
Yes, very good. Because beta blocker has prognostic benefit. Okay. Okay, 57-year-old man with NYHA class 3 heart failure is currently treated with furosemide and ramipril. What is the most suitable beta blocker to add to improve his long-term prognosis? Acebutol, labetalol, bisoprolol, sotalol, and esmolol. Here the answer is actually bisoprolol. Remember the bisoprolol and metoprolol, these are two most cardioselective beta blockers. So if you have to choose any beta blocker for heart failure patient, try to choose either these two, either metoprolol or bisoprolol. And metoprolol has also further two different types of like preparation. One is the succinate and tartrate. So among these two preparations, succinate is more cardioselective. NYHA classification is actually based on the symptom. So for example, there are actually 5 classifications in NYHA 1, 2, 3, 4. One is basically patient having no symptoms at rest. And 4 is basically patient having, like with minimal exertion or even during rest, patient is short of breath. This is NYHA classification is done mainly to assess the patient's quality of life for consideration of different type of devices. So you'll see like after the medical management fails, so there are some other devices or some interventions that can be taken to those patients. For example, implantable cardioverter defibrillator or CRT or cardiac resynchronization therapy, left ventricular assisting device. So these are particularly some intervention modalities that are available to improve the heart failure status in a patient. So in those particular patients, NYHA classification is done most of the time. Here you can see that levels of BNP, raised levels is considered when the BNP is within 100 to 400, and when the NT-proBNP is 400 to 2000. So normally what we consider is that if the patient's having more than 2000 NT-proBNP, and if the BNP level is more than 400, that is significant for heart failure. There are some other conditions apart from heart failure when the BNP level can be increased. So what are those causes? One is left ventricular hypertrophy, any ischemia, tachycardia, right ventricular overload, hypoxemia, CKD patients, COPD patient, diabetes, increased age, liver cirrhosis, burn, sepsis. In those conditions, just like troponin I or T, we know that troponin I-T is very much cardiac specific. But apart from the ischemia, there are some other conditions when the troponin I and T can get raised. Similarly, BNP level can also increase. Apart from the heart failure, there are some other conditions when the BNP levels can also increase. Drug management, okay. So this is basically one of the modality, intervention modality that is mentioned, non-drug therapy or non-pharmacological, cardiac resynchronization therapy. And the other one is actually ICD. ICD can also be given to a heart failure patient, particularly if ventricular tachycardia, ventricular fibrillation has already taken place in a patient. In that case, after 4 to 6 weeks of an MI event, in that case, like as part of secondary prevention, ICD is given. And CRT is for patients with heart failure and white QRS complex. Biventricular pacing can be done with this, and patients who are on a guideline-directed optimal medical therapy or treatment, but yet having NYHA class 3 or 4 symptoms. In that case, CRT device can be given. Exercise training, okay. This is just part of like general approach, not specific management. In terms of white QRS complex, that means when the QRS duration is more than 150 milliseconds, in that case, cardiac resynchronization therapy can be considered. However, if a patient is having left bundle branch block in the ECG, but the QRS is more than 120 milliseconds, in that case, you can consider CRT as well. I think as this is an additional information, you can write it down. Indication of CRT. GDMT means guideline directed medical therapy. If the patient is still symptomatic, in that case, you can go for CRT with QRS duration more than 150 millisecond. However, if a patient on the ECG has left bundle branch block, in that case, if the QRS duration is more than 120 millisecond, in that case, CRT can be given. Okay, so that's basically all about the heart failure. So I don't think that for part 1 examination, you have to know like more information regarding this. Now I will go through the cardiac arrhythmia topic. Okay, no, actually before cardiac arrhythmia topic, I wanted to discuss about discussing about heart failure, the management of cardiogenic shock, because this is the part of emergency protocol. Then I will go to the cardiac arrhythmia. Okay. So cardiogenic shock, you'll see that in any of the shock, there are actually mainly two components. One is cardiac output and the other one is systemic vascular resistance. So if either of these two are failing, in that case, you'll see that patient will be developing shock. So which of the shock affects the cardiac output? Number one is hypovolemic shock. And number two is cardiogenic shock. Mainly when there is, like loss of cardiac output and systemic, like vascular resistance, this is affected in anaphylactic shock. Number two, septic shock. Number three, neurogenic shock. Some special causes like endocrine shock or like myxedemic coma or Addisonian crisis, in those endocrine emergencies, systemic vascular resistance is affected. However, these are not our topic of discussion today. We will focus on the cardiogenic shock when there is lack of cardiac output. Now, what are the causes of cardiogenic shock? It can be due to intrinsic to the heart or extrinsic to the heart. If this is intrinsic to the heart, most common cause is myocardial infarction. Number two is cardiomyopathies or myocarditis, which can be either due to any infection, drugs, metabolic acidosis, sepsis, and all these things. And extrinsic to the myocardium or extrinsic to the heart would be pulmonary embolism, tension pneumothorax, and cardiac tamponade. So these are the main causes behind the cardiogenic shock. Now, how do we manage a case of cardiogenic shock? So first, again, this is the emergency. So you have to start with ABC resuscitation protocol. All right. After that, you should So after in ABC resuscitation, again, open up an IV access, keep the patient propped up, give oxygen if the saturation is low, and try to maintain oxygen saturation within 94 to 98%. However, if the patient is having any COPD feature, in that case, just maintain 88 to 92% oxygen saturation. And meanwhile, try to take relevant history and examine the vitals, go for short assessment of the patient and send some relevant investigation. Now start with the diamorphine. Particularly if the patient is having ongoing chest pain, ECG changes, or particularly if the patient is restless or agitated. And then give patient GTN spray as well if there is ischemic changes or known ischemic heart disease. And if there is any electrolyte imbalance or arrhythmia or any acid-base disorder, that should be corrected. And then you have to you have to send the patient CCU. Cardiogenic shock, there is no, need for keeping the patient in the general ward. Refer the patient to the CCU or the ICU, and then monitor the CVP, that is central venous pressure. So central venous pressure, there are different ways of monitoring the central venous pressure. In most of the CCU setting, PICO machine or LICO machine, these are used. PICO machine is basically pulse-generated cardiac output monitoring, and lithium-infused cardiac output monitoring. You don't have to know the bits and crannies of it. Another invasive way where you can check for the, central venous pressure is the Schwann-Gatz catheter. You can directly, with this Schwann-Gatz catheter, you can directly measure the cardiac output as well as the filling pressure. So you open up a CV line and monitor the central venous pressure. And if the patient is underfilled, in that case, give some plasma expander. (100 ml) IV every 15 minutes till the patient's mean arterial pressure is more than 70 millimeter mercury, or the central venous pressure is within 8 to 10 millimeter mercury. However, if the patient's CV pressure is normal or well filled or overfilled, in that case, consider giving inotrope support, that is dobutamine. Dobutamine or dopamine. Dobutamine is preferred over dopamine. And then similarly here, the mean arterial pressure should be maintained over 70 millimeter mercury, and central venous pressure should be maintained at 8 to 10 millimeter mercury. And treatment of the underlying cause. For example, if the patient is having MI, then go for PCI. If the patient is having pulmonary embolism, in that case, thrombolysis and so on. So mainly you have to, in terms of cardiogenic shock, no need to wait, send the patient to the CCU, do some ABC resuscitation, send some important investigation, including electrolytes, and do an ABG, ECG, chest X-ray, RBS, and all this investigation, and give the patient some diamorphine and GTN spray. You can go for that as well. If there is any concomitant electrolyte imbalance, arrhythmia, or metabolic acid-base disorder, that should be corrected as soon as possible. And then you should open up the CV line as soon as possible to measure the central venous pressure. And if the patient is underfilled, you can give, plasma expanders or colloid solutions. And if the patient is well filled or there is overfilled, in that case, start with dopamine or dobutamine, inotrope support. Mainly management of cardiogenic shock, treatment of choice is inotrope support. All right. Now we will discuss about the cardiac arrhythmia. একটু kindly দিবেন, একটু ওয়াশরুমে যাবো। Okay, so now we will discuss about cardiac arrhythmia or electrical abnormalities in the heart. So this is again a very important topic, and this is actually a bread and butter of any cardiologist, honestly. This heart failure and coronary syndrome and arrhythmia, these three are the important aspects or three pillars of cardiology and earning source for any cardiologist all over the world. And so we will start with some peri-arrest cardiac arrhythmia. So we will start with broad complex tachycardia. So whenever this is a case of broad complex tachycardia, the first thing that should come into your mind, that is ventricular tachycardia or ventricular fibrillation. Now, both ventricular tachycardia and ventricular fibrillation, these are bad arrhythmias. But in comparison to VT, ventricular fibrillation is worse because this is like near arrest situation. So patient is about to go into cardiac asystole or, cardiac arrest very soon. So VT patients, again, this is further two types. If this is pulseless VT, that is within the cardiac arrest protocol. But if the patient still has a pulse and has a stable ventricular tachycardia, so in that case, management is medical management should be given. Features suggesting a VT rather than supraventricular tachycardia with aberrant conduction. So in what condition you think that this is actually a case of VT? So one is AV dissociation, atrioventricular dissociation. Number 2 is fusion beat or capture beat, and positive QRS concordance in the chest lead. So all the directions of the QRS complex will be in the positive deflection. Marked left axis deviation if there is any history of ischemic heart disease or structural heart disease, and lack of response to adenosine or carotid sinus massage. And if the QRS duration is more than 160 milliseconds, in that case, it goes in favor of ventricular tachycardia. Because normally supraventricular tachycardia usually causes narrow complex tachycardia. QRS duration is very narrow. But with aberrant conduction, it can mimic ventricular tachycardia. But how we can differentiate? Mainly if the QRS duration more than 160 milliseconds, not responding to adenosine or carotid sinus massage, has a background history of ischemic heart disease or any other structural cardiac abnormality, positive QRS concordance, left axis deviation, fusion or capture beat, which kind of looks like a pyramid pattern, like I will show. So it looks like as this like QRS complexes are very big, so they kind of look like this, like one wave is merged into the QRS complex. So this is known as the fusion or capture beat. So in terms of, as we are discussing about peri-ARREST situation, I will first start with the broad complex tachycardia management, and then I will go back to the normal regular discussion. So normally, like arrhythmias are two types. One is tachy and the other one is brady. So tachyarrhythmia is considered when the heart rate is more than 100 beats per minute. Brady is when this is less than 50. Some say that it is less than 60 beats per minute. So that is bradyarrhythmia. So again, this can be further divided into like tachyarrhythmias can be divided into broad QRS and narrow QRS. Bradyarrhythmia, it has no further sub classification. If this is a broad QRS, again, it can be irregular versus regular. And narrow QRS, it can be again irregular versus regular. So if this is a narrow QRS complex, irregular, most common example is atrial fibrillation. All right. If this is a regular narrow QRS complex tachyarrhythmia, in that case, first differential would be SVT or supraventricular tachycardia. All right. And if in case of a broad QRS complex, if this is regular, this is most likely ventricular tachycardia. If this is irregular, this can be polymorphic VT. Polymorphic VT or polymorphic ventricular tachycardia. This is regular is monomorphic. So this is the main subclassification, tachyarrhythmia, bradyarrhythmia. Tachy is further divided into according to the QRS duration. If this is more than 120 milliseconds, this is known as broad QRS complex and narrow QRS complex. Narrow QRS, regular, irregular, broad QRS, regular, irregular. Narrow QRS, irregular, atrial fibrillation, main example. If this is regular, this is known as supraventricular tachycardia. Broad QRS complex, if this is regular, monomorphic VT is the primary example. If this is irregular, then polymorphic VT is the primary example. Now we will discuss about how do we manage a case of broad complex tachyarrhythmia. All right. So first we have to check whether the patient is in cardiogenic shock or not, whether the patient has any pulse or not. This is the most important thing. We will, for this reason, we will check for the carotid pulse. If the patient has no carotid pulse, so that it goes in pulseless VT. It should proceed with the ACLS protocol or advanced cardiac life support protocol, that is cardiac arrest protocol. So in that case, you have to continue giving the patient CPR till you get a pulse. So in this kind of patients, this is actually a non-shockable rhythm. So giving shock here, this will be futile. So it will be discussed in the when you're taking the ACLS course in your home country or maybe in the UK, then you will learn more about this. And now our main cardiology perspective, we will discuss with the VT that has a pulse. So if a patient has pulse, in that case, we have to check for some adverse sign. There is evidence of pulse, yes. So what are the adverse signs? Whether the patient is having any syncope, whether the patient is any cardiogenic shock, whether the patient is having any heart failure, or whether the patient is having any ischemic changes in the ECG or ongoing chest pain. So if the patient has any of these adverse signs, in that case, we have to seek expert help and sedate the patient, get the patient ready for desynchronized DC shock. So we start with usually 160 joule, and then 3 DC shocks are given, and then followed by 300, followed by another further 300 joule DC shock. And then we open up an IV line, give the patient 300 milligram IV amiodarone as a loading dose over 20 minutes, and then open up a CV line to give further bolus doses of 900 milligram over 24 hours. And if there is any electrolyte imbalance, that should be corrected simultaneously. If the patient is refractory, in that case, a further DC shock can be given after giving this amiodarone. If the patient is still refractory, in that case, there are some further approaches. For example, I start with expert help, sedation, 3 DC shock, amiodarone, electrolyte imbalance correction, further DC shock. If the patient is still refractory, in that case, consider alternative, like with cardiologist and CCU consultation, alternative antiarrhythmics such as lidocaine, and some interventions such as overdrive pacing can be done. Lidocaine, lignocaine, these medications can be given. That is a patient with an adverse sign. What if the patient has no adverse sign? In that case, how would you approach? So in that case, you have to look at the patient's electrolyte level and look for the reversible causes. If you get any reversible causes, for example, hypokalemia, hypomagnesemia, hypocalcemia, like any electrolyte imbalance, or if there is any hypothermia, so in that case, you should try to treat for the reversible causes as soon as possible and look at the ECG. If the ECG is in sinus rhythm, so for example, patient's ECG is showing regular rhythm, in that case, open up an IV line, give amiodarone and 300 milligram bolus, and then open a CV line and give further IV 900 milligram over 24 hours. But loading dose is usually given IV line, 300 milligram over 20 minutes. This is something that you have to remember. Okay. If the patient is irregular, like if this patient is having irregular rhythm or not in sinus rhythm, most of the time this is due to a polymorphic VT. In that case, IV magnesium sulfate is given 2 gram IV bolus dose, okay? This is the loading dose of magnesium sulfate. However, if going for amiodarone and Maxulf, if the patient is still refractory, in that case, you might need to sedate the patient and consider for DC shock and seek expert help anyway. So this is how you approach a case of broad complex tachycardia. Please let me know if this is not understandable by any of you. I will repeat if necessary. So for any question from this management of broad complex tachyarrhythmia? There are lots of other possibilities of, broad complex tachyarrhythmia with irregular rhythm. For example, it could be atrial fibrillation with bundle branch block or pre-excited atrial fibrillation or even atrial flutter with variable block. But those are so complex and, they're not for MRCP level. That's why I have, in a conscious mind, I have tried to omit those information. Mainly, you have to look at the ECG. If there is an electrolyte imbalance, you should try to correct those as soon as possible and seek for expert help. Give patient DC shock if the patient is having any of the adverse sign, and prepare the patient for loading dose amiodarone and IV magnesium sulfate. In broad complex tachyarrhythmia, if the patient is having regular rhythm, in that case, most likely this is a case of monomorphic VT. And if the patient is having irregular rhythm, most likely this is a case of polymorphic VT. That's all you need to know, honestly. Now let's get back to, okay, no, another is still present. That is, what if the patient is having narrow complex tachyarrhythmia? Again, you have to consider for the differentials, we will be mainly dealing with atrial fibrillation and SVT, okay? But before that, you have to check for if the patient has any adverse sign or not. So if the patient has adverse sign, for example, patient is in shock or heart failure, in syncope or hemodynamically unstable, so the patient's blood pressure is maybe, for example, less than 90/60, and the patient is having tachyarrhythmia more than 150. In that case, you have to seek for expert help and go for DC shock. Sedate the patient and go for DC shock. That is electrical cardioversion followed by chemical cardioversion. So in that case, amiodarone can be given and blah, blah, blah. So same protocol is for the both broad complex and narrow complex tachyarrhythmia. If there is adverse sign, protocol is basically same. However, if the patient is not having any of this adverse sign, in that case, look at the ECG to see whether this is regular or irregular. If this is irregular, then you have to consider this is a case of atrial fibrillation and then go for rate control and rhythm control strategy, as well as prevention of thromboembolism with warfarin or DOACs based on CHA2DS2-VASc scoring. And if this is regular, in that case, most likely this is supraventricular tachycardia or SVT. In this case, you have to go for vagal maneuver, like carotid sinus massage mainly. However, in case of acute ischemia, or if a patient is having any digoxin toxicity, or if the patient has carotid bruit, in that case, you should not be proceeding with vagal maneuver. So after vagal maneuver, if the patient is still having SVT in the ECG, then you should consider giving loading dose of adenosine. Adenosine can be start with the 6 milligram. If the patient is still not reverting back to the sinus rhythm, in that case, you can go for 12 milligram. Further dose of 12 milligram can be given. If the patient is refractory, in that case, consider rate-limiting calcium channel blocker such as verapamil. IV can be given. And if the patient, for example, if a patient has severe asthma, adenosine causes bronchospasm, in that case, you should start with verapamil from the initial part. So start with a vagal maneuver in terms of management of SVT. If the patient is still refractory, in that case, you can give adenosine 6, 12, 12, and still refractory, go for verapamil. Still refractory, in that case, if the might be having cardiogenic shock, so you might need to go for DC shock. And if the patient is for example, not tolerant or contraindicated to adenosine, start with verapamil from the very beginning after the vagal maneuver. So this is the algorithm for narrow complex tachyarrhythmia. Main focus is management of atrial fibrillation and SVT. Oh, all right. Now we will go to our theoretical discussion. Catecholaminergic polymorphic ventricular tachycardia or polymorphic ventricular tachycardia. This is an inherited form of cardiac disease associated with sudden cardiac death. So here, the polymorphic VT is taking place to those who have more genetically susceptible. It's an autosomal dominant fashion. Pathophysiology, most common causes defect in the ryanodine receptor or RYR2 receptor defect, which is found in the myocardial sarcoplasma reticulum. Features are exercise or emotion-induced polymorphic VT resulting in cardiac syncope, sudden cardiac death, and symptoms generally develop before the age of 20 years. So among young individual, if you get sudden onset cardiac syncope, so of course you have to rule out some genetic conditions first. Management is beta blocker and implantable cardioverter defibrillator. In acute condition, Maxalf can be given. Okay. Multifocal, but this is extremely rare though. This genetically polymorphic VT taking place is very rare. Commonest genetic cause behind cardiac syncope in young individual is the HOCM. Multifocal atrial tachycardia. So this is irregular cardiac rhythm caused by at least 3 different sites in the atria. As there are 3 different sites of the atria which is generating, like pulses. So that's why the P wave will have actually 3 different types of morphology. So which is demonstrated by morphologically distinctive P waves. more commonly seen in elderly patients with chronic lung disease, for example, with COPD patients. So management is treatment of the underlying cause, that is correction of the hypoxia and electrolyte imbalance. Rate-limiting calcium channel blocker are used as first line because most of the COPD patients, you cannot go for beta blocker. Cardioversion and digoxin are not useful in the management of multifocal atrial tachycardia. Again, this is also very rare. In case of the ventricular tachycardia management, you can see drug therapy is antiarrhythmic amiodarone, administered ideally through a central line, lidocaine used with caution in severe left ventricular impairment, procainamide. Verapamil should never be used in ventricular tachycardia because verapamil can cause significant myocardial depression. So these rate-limiting drugs, or sometimes even beta blockers are contraindicated in ventricular tachycardia. So verapamil never ever in VT. If drug therapy fails, in that case, you can go for electrophysiological study, implantable cardioverter defibrillator. Okay. 64-year-old man with a history of ischemic heart disease and a poor left ventricular function presents with broad complex tachycardia of 140 beats per minute. On examination, blood pressure is normal. So patient is hemodynamically stable. Fusion and capture beats are seen. So patient is having VT. So what is the first line management here? Can anyone tell? The answer is amiodarone. So two main types of ventricular tachycardia. One is monomorphic VT. I've already discussed this. Most commonly caused by underlying myocardial infarction, and polymorphic VT, where the broad QRS complex is different in each of the leads. This is known as polymorphic VT. And a subvariant of the polymorphic VT is prolongation of the QT interval. So what are the causes of polymorphic VT or long QT syndrome? Causes are divided into congenital cause, drug cause, and other causes. Congenital cause, Jarvell-Lange-Nielsen syndrome and Romano-Ward syndrome. You can remember it like in Romano-Ward syndrome, there is no deafness. But in case of the Jarvell-Lange-Nielsen syndrome, includes deafness due to abnormality in the potassium channel. Actually, long QT syndrome or polymorphic VT causes. This is very important for exam purpose. You can remember, I used to remember it like in Romano-Ward, there is D. So D matches with the deafness D, and there will be no deafness. I used to remember it like this. In Jarvell-Lange-Nielsen syndrome, there is no D, so deafness will be present here. You have to add the D. So many people have different ways of remembering things. Whichever works for you, you can come up with a mnemonic by your own. And some of the drugs that can cause long QT or polymorphic VT is some antiarrhythmic drugs, surprisingly, can cause long QT, thereby leading to polymorphic VT. One is amiodarone and sotalol, mainly class 1 antiarrhythmic drugs, and tricyclic antidepressant, SSRI, chloroquine, tarfenadine, and erythromycin. You'll see commonly in examination, patient coming to the emergency department with complaints of palpitation. On ECG shows polymorphic VT. Examination history says that he had a recent sore throat for which the GP prescribed him with tarfenadine and erythromycin. Because in sore throat, antibiotic erythromycin can be commonly given if particularly if a patient is penicillin allergic, and tarfenadine is basically antihistamine. So combination of these two drugs can lead to potentially long QT syndrome. So now how would you like to treat the patient? So that's how the questions can come usually. Other causes are electrolyte imbalance, such as hypocalcemia, hypokalemia, hypomagnesemia, acute MI, subarachnoid hemorrhage, hypothermia, and myocarditis. These can all cause long QT syndrome. Management is, if the patient has adverse sign, in that case, immediate cardioversion. So DC shock is indicated. In the absence of such sign, antiarrhythmics can be given. If these fail, then electric cardioversion may be needed with synchronized DC shock. Drug therapy, amiodarone, and lidocaine, procainamide. If drug therapy fails, then EPS and ICDs. Similarly, just go through the peri-arrest protocol. I think it will be very easy to recall. I will not actually go through the further cardiac arrhythmia because so far we have discussed so many things and so many emergencies. It might be a little bit, difficult for you to remember every information. So as a part of recapitulation, instead of going through a new topic, as part of recapitulation, I would just like to go through all the cardiac emergency management again in the next 15 minutes. Just the main summary portions. So in the first portion, we discussed about acute coronary syndrome management, okay? So in here, we discussed about the ST elevated MI management and non-ST elevated MI management. In terms of ST elevated, non-ST elevated MI, both of these cases, you have to consider antiplatelet agent. Oxygen if the patient is having saturation less than 90%, diamorphine along with antiemetic, GTN spray. Okay. And then in case of an ST elevated MI, consider primary PCI as soon as possible. If not, at least go for fibrinolysis or thrombolysis, okay, with the alteplase. And if it fails, in that case, you can go for rescue PCI. If in case of a non-ST elevated MI, you should go for Gray scoring. If the Gray scoring is high, in that case, in high to moderately high risk patients or dynamic ST or TA changes or ongoing ischemic changes or secondary risk factors, for example, diabetes, CKD, heart failure, ejection fraction less than 40%, recent PCI, CABG, in those particular patients, you can optimize the drug therapy by providing with fondaparinux or bivalirudin. Give statins, ACE inhibitor, even consider IVGTN if the blood pressure is too high, and go for angiography within 72 hours. And if the patient is having low risk, in that case, just continue medical management and refer the patient for OPD visit for further tests like stress echo or ETT later on. Like non-invasive procedures are preferred for low-risk patients. All right. Next up, we discussed about management of acute heart failure. Here, propped up position. High flow oxygen and morphine, along with antiemetic, diuretics, furosemide, and GTN. Particularly if the blood pressure is more than 100, in that case, GTN spray or IV GTN can be given. If the patient is refractory, then you can consider CPAP or continuous positive airway pressure. If still not managed, in that case, refer the patient, treat it as case of cardiogenic shock. Then we discussed about management of cardiogenic shock. So mainly here, oxygen, morphine, treatment of complications such as electrolyte imbalance, acid-base disorder, arrhythmias, and keep the patient in the ICU or CCU and measure the CVP. If patient is underfilled, in that case, colloid or plasma expanders are given. And if this is a case of well-filled or overfilled patient, in that case, inotrope support, such as dobutamine. All right. Next up, we discussed about arrhythmia, management of arrhythmia. First one, we discussed about broad complex tachyarrhythmia. And secondly, we discussed about the narrow complex tachyarrhythmia. So in case of the broad complex tachyarrhythmia, first is whether the patient has any pulse or not. If no pulse, CPR. Okay, if the patient has pulse, look for adverse sign. If adverse signs are present, in that case, call for help, sedate the patient, DC shock, and 3 DC shocks, loading dose amiodarone, and correction of electrolyte imbalance, further DC shock if the patient requires. And if still patient is refractory, in that case, with high specialty consultation, other antiarrhythmics such as lidocaine or overdrive pacing, this can be given. Now, if the patient has no adverse signs then look at the ECG. Meanwhile, treat for any underlying reversible causes like electrolyte imbalance. If the patient is having monomorphic VT or regular sinus rhythm, broad complex QRS, then treat it as a case of VT. So amiodarone is the main modality of treatment. If this is irregular, treat it as a case of polymorphic VT. So in that case, IV loading dose max alpha is given 2 gram. Okay. And if this is a case of broad narrow complex, I will use another page. If this is a case of narrow complex tachycardia, in that case, look for the adverse sign. If there is adverse sign, then it will be similar like that of the broad complex tachyarrhythmia. However, if there is no adverse sign, in that case, look at the ECG. If this is irregular, most likely this is a case of atrial fibrillation, and management of atrial fibrillation protocol will follow, which I will explain in the next second class. And if this is regular, in that case, this is a case of SVT most likely. So start with vagal maneuver and give adenosine 6, 12, 12. If adenosine cannot be taken, or if the patient is still not refractory to these procedures or these steps, in that case, verapamil or calcium channel blocker is given. Another important information from the broad complex tachyarrhythmia is that in any form of VT, whether be it a polymorphic or monomorphic VT, never give verapamil. Never. Or any myocardial depressing drugs or negative inotropic agents. These are absolutely contraindicated in ventricular tachycardia or ventricular fibrillation. Okay, so far, any questions? Let's try to go through some of the questions here. Like, for example, this one, if you have a look at this one, you're called to the coronary care unit. Patient who has been admitted following a myocardial infarction has developed a broad complex tachycardia. You suspect a diagnosis of polymorphic VT. So which of the following factor is most likely to have precipitated it? The reason why we give magnesium in case of a polymorphic VT is because one of the potent risk factor for polymorphic VT is hypomagnesemia, which is why this will be the answer, hypomagnesemia. All right. Now, let's see 124. A 47-year-old lady with family history of sudden cardiac death developed palpitations while visiting a relative in the emergency department. When attached to cardiac monitor, her heart rate was 164, tachycardia, and rhythm strip showed a broad complex tachy. So which antiarrhythmic may precipitate ventricular fibrillation if used in such circumstances? The answer is, in VT patients, which antiarrhythmic will precipitate ventricular fibrillation or make matters worse? Yes, verapamil, yes. Verapamil should not be given in patient with VT. Okay, so I think I would like to conclude my session. So far, I've discussed lots of things. I hope you may be able to keep this information and just go through whatever I've read so far in the lecture. Try to see if I have said anything that was probably wrong or anything like that. Hopefully not. And if you have any questions, let me know in the group chat. Practice some of the questions so that in the second lecture, it will be a bit more palatable for you. All right, thank you so much. Take care.